So, so my daughter said I look like a YouTube star. All of this YouTube stuff that YouTube stars have. So thank you for being part of this virtual world that we're in here. I hope that we can, I know that we'll learn a little bit today about a very important piece of our work with working with folks with gambling problems. So I'm very pleased to introduce Dave Ledgerwood, who's a clinical psychologist, PhD, and associate professor of substance abuse research division at the Department of Psychiatry, Behavioral Neurosciences at Wayne State University up in Detroit, but he is a full Canadian.
Yes.
Joining us in this international training today. He's published several research studies on problem gambling, focusing on co-occurring psychopathology, PTSD, trauma, impulse control, executive functioning, treatment outreach, and treatment effectiveness. He also is has been a paneled provider of problem gambling treatment services in the state of Michigan and the past president of the Michigan Association of Problem Gambling. In addition to problem gambling, Dr. Ledgerwood studies treatments for substance use disorder, and he is the director of nicotine and tobacco research division at Wayne State University. So thank you, and please help us welcome Dr. Ledgerwood.
Thank you, Heather. It's great to see you.
Nice to see you.
It's been a long time.
Yes.
I'll just jump in then. I'm going to grab my presentation here and we'll get going. So thanks everybody for inviting me to give this talk today. As you might have been able to tell from the beginning comments, I've done a few talks in Ohio, and I really enjoy Ohio. I really enjoy my time in the past driving around Ohio, starting in Windsor and Detroit, and driving over to Cleveland and down to Columbus and places like Dayton and stuff, and then back up and giving talks in all of those places, which I've had a chance to do in the past a few years ago actually now. Today in the new world, we've got Zoom, so I don't have to do all that driving, and I probably would have a little bit of a hassle at the border anyway if I did. So in this case, I get to reach out, I think, to more people, and it's a little bit easier because no one has to think about driving long distance or anything like that. So I'm going to talk to you today about an area of research that I think is really important, and it's parts of this research have been parts of my own research over the years. I've been doing problem gambling work since the late 1990s, and I started in that area when I was a graduate student, and I was doing work with people with opioid use disorder, so they're in methadone treatment, and realized that this patient group that I was working with had rather high rates of gambling problems. And this was in the city of Detroit in the late 90s. There was a big casino in the city I lived in, which is Windsor, Ontario, and I'll show you that casino in a minute. But there were no casinos in the city of Detroit, and we found that almost a third of our patients who were in treatment for opioid use disorder had a gambling problem at some level. They either had pathological gambling or they had what we call problem gambling, which is subthreshold. So that got me really interested in the processes around gambling disorder and sort of what those were, and whether or not there were some similarities between gambling disorder and substance use disorder. And that sort of leads me to my talk today. I'm going to talk a little bit about the brain. I'm going to talk about reward processing. I'll talk about addiction broadly, and things like impulsivity, which are really important. My understanding is if you have any questions, that you could text them or use the text function, and maybe we can save them until the end of the talk, and I'll try and leave some minutes for questions in case you guys have any questions as we go through. So as I mentioned, I am from Windsor, Ontario, and I work in Detroit, Michigan. And this is what Windsor, Ontario looks like in non-COVID times. So you see the top left in the summertime, you know, down by the river. This is the Detroit River, lots of people. The casino, which has been actually closed for several months and just actually reopened in the last few weeks to high rollers, basically to invited high rollers. In the picture on the right-hand side, you can see the skyline of Detroit across the river from our Peace Fountain, which is sort of really, you know, we're about a mile away from the United States. So technically, my house is 2 miles away from where I live, but it takes me a little bit of time to get over there. So we're just up the river. So I just want to say hello to my neighbors in Cleveland because we're really close to you guys. All right, some basics before we jump into this. Gambling, you guys all have heard these definitions before. To play a game for money or property, or to bet on an uncertain outcome, to stake something on a contingency, or take a chance, or to place something of value at risk for the chance of obtaining something of greater value. We often use these terms to define what gambling is, right? Sort of what is the spirit of gambling? It's placing something of value at risk for the chance of obtaining something of greater value. And in my mind, and from the perspective of the brain and how we process gambling, the key word here is risk. And risk meaning what we put at risk for the chance of getting a greater reward. So risk and reward are sort of the two R's that I would have you take away as we sort of continue this talk. Now, of course, you guys have all heard the old adage that what happens in Vegas stays in Vegas. I think this is a slogan that's not used as much anymore in the Vegas ads, but it's one that everybody remembers. But of course, this old adage or slogan doesn't necessarily just apply to Vegas. And there's an article a few years ago that was titled, What Happens in Vegas Happens Everywhere, because now we have legalized gambling everywhere. And before 1964 in the United States, at least in the 20th century, the middle of 20th century, the only place in the United States where we had legalized gambling was Nevada, so Las Vegas, Reno, and so forth. 1964, we had the first state lottery outside of Nevada pop up in New Hampshire. If we fast forward to the late 2010s, we see that the landscape has completely changed. At that point, almost the entire country has casino gambling, legalized casino gambling. There are other states, including Vermont and Kentucky and Tennessee and so forth, that have other forms of gambling like racetracks or lotteries. And at that point, there's really only a couple of states in the United States that don't have any legalized form, Utah and Hawaii. I'm not sure if Hawaii has actually moved towards legal gambling as yet, but there was some movement in that direction. The two little stars there, and some of you who are really astute students of geography will note that my map is unfortunately missing the Upper Peninsula of Michigan. So that was a bit of an oversight, but the two stars there just show how close Detroit or Windsor, whatever you want to, however you want to frame it, and Cleveland are. We're just up the road from each other. There have also been some major changes in the last decade around gambling disorder and what gambling disorder is. And I'm not going to get into those because they're sort of basic things that I think you guys have probably already learned about quite a bit. But I just want to summarize a few changes that occurred between the DSM-4 and the DSM-5. And those are that basically in DSM-4, what we called pathological gambling, which we don't call it that anymore, was classified as an impulse control disorder, not otherwise specified. So it was it was sort of combined with things like hair pulling and kleptomania and intermittent explosive disorder and so forth. Now it's actually considered an addiction alongside the substance use disorders. The name was changed from pathological gambling, which was considered derogatory, to gambling disorder or disordered gambling. You used to need 5 out of 10, at least 5 out of 10 symptoms to get a diagnosis of pathological gambling. One of the symptoms, illegal behaviors to support gambling, has been dropped. And now you need at least 4 out of 9 symptoms for a diagnosis. The reason that the illegal behavior symptom was dropped was because it really didn't distinguish people who had gambling disorder and those who didn't. So if somebody had enough symptoms to essentially get a diagnosis of gambling disorder, the likelihood that that they had, or if they didn't have quite enough symptoms, rather, the likelihood that they would say they engaged in illegal behaviors to support their gambling was very, very low. So it wasn't very informative in terms of keeping. Gambling disorder is the very first disorder that is now considered an addiction alongside the substance use disorders. So alcohol use disorder, opioid use disorder, cocaine use disorder, nicotine use disorder, and so forth. And there's a reason for that. And part of the reason for that is that there's far more research on gambling disorder in terms of biological mechanisms, which we're going to talk about today, treatment approaches that are efficacious for helping reduce gambling, and so forth. And we're going to talk a little bit about the first point, which is the biological mechanisms, but we're going to talk a little bit about how that might be related to treatment as well. But what we found in the literature is that there are a lot of similarities between substance use disorders and gambling disorder when we're talking about these. So let's get right to the mechanisms underlying gambling disorder. And you'll remember that definition that I just sort of gave to you a minute ago. Gambling, it occurs when you place something at risk in order to obtain something of a greater value. And for those of you who don't read Spanish, this just says, be careful. There are crocodiles in their natural environment. This was a picture I took in Mexico a couple of decades ago, actually. I did not actually crawl up snout to snout and take this picture of this crocodile. It certainly looks like I did, and I like to sort of claim that I did, but I was really on a very safe wooden platform, so this guy couldn't get me. But this just sort of signifies this idea that we take risks in life all the time. But the risks that we do take are generally calculated risks, where the potential reward is consistent with the payoff. When you think about gambling, you think about reward and risk, and you think about sometimes people who gamble in such a way that they lose a lot of money, that that sort of ratio between reward and risk is out of whack, right? It's these folks seem to process rewards in ways that are differently than those of us who don't have addiction processes. Another way to look at impulsivity is sort of reflected by this sign here. So the sign says, caution. This sign has sharp edges. And then in smaller letters, it says, do not touch the edges of the sign. And then in very, very small letters, it says, also the bridge is out ahead. So you would think, in looking at this sign, that the most important information is probably that the bridge is out ahead. But it's sort of relegated in very small letters to the very bottom of this sign, and there's all kinds of big, loud images saying, don't touch the sign, it's got sharp edges. Well, if I see a sign that says, don't touch the sign, it has sharp edges, I think there's a pretty good chance I'm going to go up and test that theory. I'm going to go up and test the sides of the sign, see if they're sharp, and I will completely miss that important information at the bottom. Well, impulsivity, in addition to taking risks, also involves not being able to pay attention to and act on important information, right? So in this case, most important information is that the bridge is out ahead, but the sign is warning you that it's sharp. People who are more impulsive, who have more difficulty focusing, have difficulty attending to the most important parts of a message. And that's one sort of element of impulsivity that we look at from a research and a clinical standpoint. A third type of impulsivity is sort of the classic Dennis the Menace type of impulsivity. And you see Dennis the Menace sitting here facing the corner, obviously in a timeout, being punished by his parents. And at the bottom of the cartoon, it says, by the time I think about what I'm going to do, I already did it. So this is the idea behind impulsivity of I act before I think. I don't think things through, and it gets me into trouble. So I think you're starting to see a theme here that there's different sort of aspects of impulsivity. So there's this risk-taking, is overly sort of risk-taking. There's this idea of not paying attention to the important information. And then there's this idea of acting before thinking, right? Well, there's another type of impulsivity too that's just as important and is very much related to these other forms of impulsivity. And this is around reward processing. And it's a concept that we call discounting of delayed rewards. And you can think about this in a way similar to delayed gratification. And those of you who know some of the psychological literature might remember studies back in the 1970s called the marshmallow experiments, where researchers sat kids down and they put a marshmallow in front of a young child who was being videotaped. And the research assistant basically said, if this marshmallow is sitting here in 5 minutes when I come back, I'll give you a second marshmallow. Well, then the researcher leaves the room, the child is being videotaped and timed from the time the researcher leaves the room to the time that the child eats the marshmallow. And the shorter the time period is, the more impulsive the kid is. Well, there's that, and also younger kids also tended to eat the marshmallow a little bit quicker because impulsivity tends to decrease with age. But you can imagine what this would look like in adults. So we call it discounting of delayed rewards, and we often measure that in terms of money or hypothetical dollar amounts. So for example, if I asked you if you'd like $1,000 now or $1,000 in a month, almost everybody would say, I'll take that $1,000 right now because I'm not going to wait a month for the same amount of money. If someone said, I'll give you $900 now or $1,000 in a month, many of you would probably still wait the month and we'll probably take the $900 now rather, but a number of you would also potentially wait another month to get an extra $100. If I drop the dollar amount to say $500 now or $1,000 in a month, a lot more of you, and maybe even almost all of you, might say, well, if you're going to give me an extra $500 just for waiting a month, I'm going to wait for that $500. Now, that's one way to look at it, but what if you extended the delay period from 1 month to 1 year instead of 1 month? Those of you who are asked if you'd like $900 now or $1,000 in a year, who said, when it was a month, said, I'll wait for the extra $100, may not be willing to wait a whole year for $100 and may change your answer to $900. And that may also be true of the $500 level. If you're given the choice of $500 now or $1,000 in $500 now or $1,000 in 1 year, many of you may change your mind and say, no, I'm not waiting a whole year for $500. I'm going to take the initial $500 right now and give up that other $500. So everybody does this. Discounting of delayed rewards is something that every human being does to a certain extent, but there's a lot of variability. Some people discount delayed rewards really steeply, and some people don't. And one of the things that we've found over the course of many years of addiction research is that people who have substance use problems have a tendency to discount delayed rewards at a rate that's much more steep than do people who don't have any sort of addiction. We did a study that we published some years back where we actually did this task, this money task that I just demonstrated to you, with people who had what we called at the time pathological gambling and people who had no addiction history. And we divided those folks with the gambling disorder history up into those who also had a history of substance use disorder or those who didn't have a history of substance use disorder. And you can see in the graph in the bottom right here, the curves in terms of at what point did people switch from taking the money, the delayed amount, the delayed $1,000 to the immediate amount. And you'll notice that there's basically 3 slopes here. There's one slope that's sort of at the top here, that's all by itself, and there are 2 that are almost on top of each other down below, quite a distance below. The slope at the top was the control participants who had no history of addiction. The 2 slopes down closer to the bottom were the people who were diagnosed with pathological gambling and included both those with and without histories of substance use disorder. In fact, we found virtually no difference between those two groups. So what does this mean in terms of treatment? Well, it means that people with gambling disorder have a tendency to discount delayed rewards at a much steeper rate than do people who don't have addictions. And that can translate over into treatment, for example. This study sort of focused on money, but you can imagine someone coming in, and if you ask that person, what are your goals for the future? Where do you expect to be a year from now, 5 years from now? How would you like your life to be different? A lot of the gamblers I've treated over the years, if I've asked them that question, have looked at me blankly and said, I have no idea, I'm just working on today and tomorrow. And that's because they have a lot of difficulty dealing with this sort of delayed reward, this ability to sort of see their life, several months or years into the future. And I think that's an important consideration, and it's also related to brain processing, as we'll see. So broadly across nearly all measures of impulsivity, people who have gambling disorder tend to score higher on impulsivity measures than do those who don't have any gambling disorder or gambling problems. Generally, these folks tend to score similarly to those who have substance use problems, but this is not always the case. And as I mentioned to you, higher impulsivity is associated with poorer treatment outcomes in gambling disorder. It's also associated with higher treatment dropout. So part of that is what I just mentioned to you about discounting of delayed rewards. People who have a gambling problem have a tendency to sort of go for the immediate reward right now, which may be going out and gambling and sort of forgetting about one's problems for an evening, as opposed to the oftentimes tougher but bigger rewards that happen in the future, for example, recovery, right? So that makes it challenging to treat people with gambling problems. So another brain sort of cognitive concept that I also want to sort of present to you is the idea of executive function. And when I talk to you about executive function, you'll be able to see how executive function is sort of conceptually similar to what we've been talking about in terms of impulsivity. So for those of you who don't know this definition, I'll sort of read it out. Executive function involves higher level cognitive processes implicated in the formation of successful goal-directed behavior, including planning and initiating behaviors, anticipating positive and negative consequences of actions, and the ability to adjust behaviors based on environmental feedback. So this is sort of a long-winded way of just sort of saying executive function involves all of those processes that people use to learn from their environment and to maximize their rewards and minimize any punishments, right? So you don't want to make mistakes that lose you money, for example. You want to do things that get you more money, right? You want to be able to sort of look at your actions and how they interact in the world and see which ones benefit you and which ones don't, right? Well, when we think back to delayed discounting, you can think about a gambler, for example, who maybe has the option of putting a proportion of his or her salary into a long-term retirement, like a 401k plan or something like that. If a person puts their money in a 401k plan and lets it sit for 20 years, then they are almost assured of a very large payout when they eventually retire. But that's a very long time to wait for that money. If a person gambles, they're almost assured, if they gamble enough, that they're gonna constantly lose money because the house edge doesn't allow over time for somebody to actually win a lot of money. So somebody who looks at it that way would be able to say, well, I should be putting my money in a 401k and not going to the casino. But people with gambling problems seem to have some difficulty processing rewards in such a way, and part of that might involve executive function. And we'll talk a little bit about some of these executive functions. The four that I tend to work with and we've published on in the past include response inhibition, or an ability to respond to a stop signal after being presented with a go signal. So you might imagine driving down a familiar road, maybe going to your office at work, and you're coming up on an intersection where you know if the light turns red or yellow rather, at a certain point you're going to stop. But if you're past that point of no return, then you're going to go through the yellow light. Well, what would happen if that light turned instead from green, didn't turn from green to yellow, but rather turned from green directly to red? You would have to very quickly change your schema, change the rules in your head as to what you're going to do. And response inhibition is sort of your ability to do that, to sort of respond to unexpected stop signals when you've been given a go signal, right? So that's one part of executive function. A second piece is working memory, or the ability to maintain attention to details essential in planning. So can you maintain sort of the steps in your head for something you need to do long enough to actually complete that task? The classic example is, how long can you remember a 7-digit phone number in your head? Let's say someone gives you their phone number, and your notepad or your book that you write your phone numbers in is in another room, and you have to remember the phone number until you get to that room. Well, that in part involves your working memory, your ability to maintain attention to those sorts of details for a brief period of time until you accomplish that step in your planning process. The third type of executive function that I often look at is called cognitive flexibility, or the flip side of that is called perseveration. So the ability to shift one's thoughts or actions to fit the demands of a situation. And one way to look at this is if you imagine that you're playing a video game, a computer game, and you know the rules of the computer game, you know how to get points, you know how to play so that your avatar doesn't get killed, that sort of thing, and you're doing great playing that game. But then there's some kind of programming built into the computer that changes some important rules on you mid-game. So all of a sudden, the rules that you were playing by don't help you play anymore, and you have to figure out the new rules. Well, people who are fairly high in cognitive flexibility would be able to figure out those rules pretty quickly. People who are more perseverative, who have more perseveration, would have much more difficult time. So that person might continue to keep making mistakes and not be able to figure out what the new rule is. And you could think about that in terms of as we age, for example, we have a tendency to have less cognitive flexibility and more perseveration as we get older. So it's more challenging for us to shift our set, basically, to shift from one way of interacting to another way of interacting quickly, right? And the fourth type of executive function that we really sort of focus on involves all of these other ones, and is, I think, the most important aspect of executive function is planning. It's the ability to identify and organize elements needed to carry out a planned act or achieved goal. So you can imagine, for example, that you want to take a vacation. For a lot of us, vacations are probably in the distant future, but let's say we can take vacations now. And that vacation was in another country, you would have to go through numerous steps to figure out how you're going to accomplish this vacation. So you have to see when you can take off work. You might have to book off work. You might have to check on airfare. Might have to book a flight, check on hotel prices and book a hotel, get your passport, maybe get some family members' passports updated. Make sure it's in your calendar so you don't forget. So there's a lot of steps there, right? And then involves things like working memory, so remembering to do all of these things. It involves cognitive flexibility, because if let's say one flight is booked or there's not enough seats on a flight, you have to scramble to find another flight. Say one hotel you thought had rooms available, all of a sudden doesn't. So all of these things come together when we try and plan something more complex, and these are important sort of aspects of executive function. They're things that we need to have the ability to do, to usually just live, to do the things that are important to us, to go to work, to have a complicated job like many of us do, in terms of like juggling large client loads and juggling lots of paperwork and all of these things. We have to have good executive function. Impulsivity and executive function deficits impair a person's ability to learn from their experiences, to make plans based on long-term consequences of their behavior. And we know that treatment is geared towards long-term consequences. As I mentioned to you previously when we were talking about discounting delayed rewards, those people with gambling disorder may have greater difficulty benefiting from treatment in some ways. And so I often suggest when people are starting to work with people in treatment that they focus on, initially at least, on shorter term goals. And there are also ways that, that you can work towards helping people work towards longer term goals, but it's sort of a gradual process. You start with the short term, immediate things that a client can address, and you gradually increase the scope, like the future scope of the goals that you introduce in therapy. So that sort of talks about function and how we function from a reward standpoint. What does this look like in terms of the brain? And well, first of all, I mean, does executive function deficit exist in people with gambling problems? I'll just present this one study really quickly. This is a slightly older study now by Goudriaan. What she did was she recruited 49 people who were diagnosed with pathological gambling, 48 people who were diagnosed with alcohol dependence, 46 people diagnosed with Tourette's syndrome, and 49 people who were otherwise healthy control participants who didn't have any of these problems. And she included a number of measures of executive function, including response inhibition, time estimation, cognitive flexibility, working memory, and planning. And I'm just going to present a couple of charts here just to show you the scope of this and how this is sort of related to the substance use disorders. So on this graph, you can see here that there are a number of numbers called z-scores on the left-hand side. The bottom are a number of different tests that look at different types of executive functions that we had already talked about. Some of them we'd already talked about. This line, the zero line, the straight zero line, is the line that represents the healthy control participants. So these are the folks who don't have any addiction processes or Tourette syndrome. And the other lines are basically the scores in relation to this zero line. So as you can see here, when we look at people who had gambling disorder or pathological gambling in this particular case, you can see that relative to the control participants, those with pathological gambling had greater difficulty with response inhibition, so that stop sign, inability to respond to a new stop signal. They had greater difficulty with cognitive flexibility. There are a couple of measures called the Wisconsin card sort test that some of you may have actually heard of before. Another one called a verbal fluency task, where people are asked to name as many words they can in a certain period of time that begin with a particular letter. So that's another measure of cognitive flexibility. There wasn't really a lot of difference in working memory, but there was certainly a difference here in terms of ability to plan. So what Goudriaan et al. was finding was that people with gambling disorder had deficits in response inhibition, cognitive flexibility, and planning compared to healthy control participants. Now, if we add another line here, these folks were the individuals who had alcohol dependence. And if you look at where the red line falls relative to the blue line, it's a little bit jagged, comparatively speaking. But overall, if you look at the sort of the general trend here, you can see that the red line mostly reflects or is similar to the blue line. So you're seeing that people with alcohol dependence had poorer scores relative to control participants on the response inhibition tasks, the cognitive flexibility tasks, to a certain extent, and also the planning tasks. So we're seeing that despite the fact that gambling disorder doesn't actually really include ingestion of a substance or problems related to ingestion of a substance, from a functional standpoint, from an executive function standpoint, their responses are actually quite similar to those folks who have alcohol dependence, which is really interesting from the standpoint of, alcohol is clearly a toxic substance and has major effects on the brain. And we're seeing similar responses among people with gambling disorders as well. So the early studies suggest that people with gambling disorder exhibit executive function problems, and those are similar to people with substance use problems. So I'm going to move now, and that was the sort of the functional aspect of the brain and how people function. Well, what does the brain actually look like in terms of how does it light up when we're sort of having people engage in tasks that are like gambling or that are reward processing types of tasks? And there's been three main areas of study when it comes to looking at reward processing in imaging types of studies with people with gambling disorder. And the reward processing stuff we'll talk about first. Then I want to talk about near-miss outcomes and also craving and cue exposure types of research studies. So in terms of reward, we've covered some of this already, but when we talk about the brain and we talk about reward processes, there's a couple things to keep in mind. And there's a couple of really good sort of quotes here from some really seminal research reviews. One of them is by George Koob, who is actually the head of the National Institute on Alcohol Abuse and Alcoholism. And there's by Nora Volkow, who's the head of the director of the National Institute on Drug Abuse. And in Koob's article, he noted that a major process in addiction involves a compromising of the reward system through the chronic underactivation of natural motivational systems. So what Koob is basically saying is that the normal reward systems that we use in everyday life are compromised in addiction. Kalivas and Volkow sort of add to this idea sort of a little bit more specifically and say addictive disorders create a dysregulation of cellular and circuitry functions of the brain, such that non-drug motivational stimuli lose salience, decision-making abilities are impaired, and there's a profound activation of the prefrontal cortex and glutamatergic drive to the nucleus accumbens when predicting drug availability. So just to summarize these two quotes, what they're essentially saying is that when a person has an addiction, the addictive behavior and engaging in the addictive behavior compulsively for a long period of time hijacks the normal reward processes of the brain. If you look at Kalivas and Volkow's quote here, they're talking about some brain areas. So for example, if we look at what they're sort of saying, the prefrontal cortex is that part of the brain that's focused in on executive function, the ability to make good decisions and learn from the environment. The nucleus accumbens is that part of the brain that creates dopamine and sort of is basically the pleasure center of the brain. And we're going to talk a little bit more about that. Just very briefly, I don't expect you to sort of know all of these brain regions or to understand how they all work perfectly. This particular diagram shows the important regions in the brain that are really sort of associated with addiction processes and reward processes related to addiction. And you'll see at the very front of the brain, an area called the dorsolateral prefrontal cortex, and another called the ventral medial prefrontal cortex. It's not so important that you remember that, but just know that these are the frontal parts of the brain that are responsible for executive function and making good decisions. If we look at the striatum, that's the part of the brain that's really focused on reward processing, and the insula is actually part of the brain that's responsible for self-awareness, so being aware of oneself. So cravings, for example. The insula is an important part of the brain when it comes to cravings and experiencing cravings for drugs. The amygdala is an important center of the brain for emotion regulation and forming emotional memories. And the hippocampus is also important for memory formation. So just very briefly, again, in terms of parts of the brain, because this is sort of important for our talk, but it's important that the broadly speaking that you know kind of what some of these areas do. The striatum includes areas that you might have heard of like caudate and putamen. These areas coordinate motivation within the body and body movement, and they're associated with reward and decision-making and executive function. So that's those middle parts of the brain, the striatal areas of the brain. Nucleus accumbens is our pleasure center. Dopamine is increased when there are drugs on board. And even cues from the environment can result in dopamine release in the nucleus accumbens. So seeing a person open a bottle of whiskey could increase dopamine in the nucleus accumbens in somebody who has an alcohol use disorder, for example. The prefrontal cortex are those two frontal regions of the brain that I mentioned to you. And these are executive function regions that regulate overall motivational salience and help determine the intensity of your response to things in the environment. Hippocampus helps in the formation of normal memories about events that you've experienced. The amygdala involves memory and emotional reactions and emotional memories. And the insula or insular cortex involves consciousness and self-awareness. And those are important functions. All of these are important in terms of understanding the reward processes in the brain and our decisions. So again, back to this idea of reward processing and impulsivity. I don't know how many of you play Powerball, but back to our original definition again of gambling. Gambling involves placing something of value at risk to get something of greater value. And we generally take calculated risks. And for most of us, buying a Powerball ticket or two is a calculated risk. And if any of you have ever been interested in knowing what the odds are of winning Powerball, to win the grand prize, the odds are about 1 in 292,201,338. So almost one chance for every person in the United States. Well, that doesn't seem like a very good bet, does it? If you look at the chance of winning $4 on a Powerball ticket, your chances are about 1 in 38 for one combination and about 1 in 92 for another combination. So when at first glance, buying a Powerball ticket doesn't make a lot of sense because the likelihood that you're actually going to win something is very minimal, except if you step back and you say, well, a Powerball ticket doesn't cost very much, so it's not a big risk. And second of all, you may be buying something other than the chance to win the grand prize. You may be buying a fantasy, some kind of thing that you can think about for a while and gives you a warm, fuzzy feeling like maybe I'll win, right? So buying a Powerball ticket has other value in addition to the chance of winning the grand prize. So we usually, if we buy a Powerball ticket, not a big deal. It's not a big risk, it's not a lot of money, makes us feel good for a little while. Well, in addictions, when we're sort of thinking about this, that dopamine response, and a lot of us might actually get a little burst of dopamine when we buy a Powerball ticket, even though there's no chance we're going to win the grand prize. When we look at substance abuse, the substance abuse literature, and we look back over decades of research, studies have found across many different substances that there are reductions in dopamine 2 and 3 receptor availability in response to natural rewards across people who have dependence on numerous different substances, including nicotine, so smokers, people with alcohol use disorder, people with cocaine use disorder, and people with methamphetamine use disorder. And the picture on the left is a classic diagram from one of Nora Volkow's early PET imaging studies, looking at a PET image of the striatal parts of the brain when sort of exposed to a rewarding stimuli in a comparison subject and a subject with methamphetamine use disorder. And what you see is there's much greater activation in the person who doesn't have an addiction. That's because there tends to be a blunted activation in people with addictions and sort of less availability of dopamine receptors. Well, the question then becomes, does this happen with gambling disorder? And there have been a handful of studies that have looked at this with mixed results. So there has been one really good study that was done by Steves and colleagues, published in 2009, where they did a similar PET imaging study and found decreased D2 and D3 receptor availability in problem gambling participants that was not seen in people who didn't have gambling problems. Well, the one problem was this was a very specialized group of patients who also were in treatment for Parkinson's disease. And many of you may be aware that there's quite a lot of research literature showing that some people with Parkinson's disease who are treated with dopamine 3, D3 receptor agonist meds like pramipexole and L-Dopa monotherapy can go on to develop reward-driven compulsive behaviors like gambling or compulsive shopping or hypersexuality, and the treatment for that is usually to decrease or discontinue the dopamine agonist medication. So this is a specialized group, which might sort of say that basically these findings are not all that representative of all people with gambling problems. There have been a few other studies. One other study by Joustar and colleagues did a similar PET imaging type of research protocol and found no differences between people with gambling disorder and control participants on dopamine release while they were doing a slot machine task. But what they did find was when they only looked at the people with gambling disorder, there was a correlation between dopamine release and gambling severity. So there was less dopamine release in people who had much more severe gambling disorder than people who had less severe gambling disorder. So we are seeing similarity with substance use disorder in that there may be decreased blunted dopamine receptor availability when someone has a gambling problem, but the case is sort of still out there. There needs to be more quality research to figure that out. A second way to look at this is the near miss phenomenon. And it's a little bit big of a group here to do a discussion, but so I'll just sort of describe it. Many of you have probably heard of this near miss phenomenon, and I'll just sort of present the classic example here. Near miss phenomenon is when you're engaged in a gambling game and you end up with an outcome that you feel like is just almost a win. You just barely missed winning, right? So in this case, on a slot machine, you get a 7, and then you get a 7 that doesn't cross the line. So it basically looks like you almost won, but in fact you completely lost. You lost that slide. So another type of near miss phenomenon might be if you're playing blackjack at a blackjack table and you get 20 and you hold, and then the dealer gets a blackjack, right? You almost won, but no, the dealer beat you. A third might be if you get a really good hand at poker and you think, I'm about to win this pot, and then someone across the table from you has just a slightly better hand and you lose, right? All of those things might be considered near miss phenomenon. So we sort of talked about this, but I want to talk about a study that was done. And there are a few studies, most of them done by Luke Clark and his group. Luke Clark is a neuroscientist who is at University of British Columbia in Canada. He used to be at Cambridge in the UK. But in this particular study, he and his group did an examination of a near-miss phenomenon with people with gambling problems and non-gambling problems, and also looked at dopamine, like we've been talking about. So the idea behind this study was that that there might be enhanced gambling-induced dopamine released in the striatum when a person wins, right? And D3 receptor binding in the substantia nigra, which is a part of the brain that produces dopamine, positively correlates with gambling severity. High dopamine is associated with increased risk taking in healthy humans, and the D2 and D3 receptor agonists tend to increase agonists, which are medications that increase dopamine production, tend to also increase risk taking. So they hypothesized that if they could alter dopamine transmission with something called an antagonist, or something that reduces the availability of these dopamine receptors, and this medication was called sulpiride, that they would be able to alter reward process responses in response to near misses among people with gambling disorder. And so what they did was they recruited 44 people. 22 were men with gambling disorder, 22 were men who were control participants, and they tested them twice. They did MRIs twice with them, once after the sulpiride medication, which was an antagonist, and once after a placebo. the tests were 1 week apart, and they were randomized so that the participants and the researchers didn't know which week they were getting the sulfuride and which week they were getting the placebo. And they created a slot machine. And the slot machine task looked basically like this. This idea of, the participant got to press a button. They bet a certain amount of money, press a button. And if they ended up with the two icons being the same next to each other, then they won a certain amount of money. If the two icons were not the same, then they lost the money. And in this case, you see it's a full miss because there's a watermelon on the left-hand side and there's no watermelon on the right-hand side. Or they might have gotten a near miss outcome where you see there's a watermelon here and then the watermelon just above the winning slot, right? And then there were a number of different ratings that they did at this point. So one of the first things they did was after each type of response, they asked participants, do you want to continue gambling after each type of response? And not surprisingly, those folks who had gambling problems wanted to continue gambling regardless after each spin compared to the control participants. When we look at the types of responses that they had, whether they won on that roll, whether they had a near miss on that roll or full miss, over here we see that people, once they won, their motivation to continue to gamble was significantly and quite a bit higher than the near miss and the full miss scenarios. But we can also see that there's a significant difference between the near miss and the full miss. So people who had a near miss experience wanted to continue gambling at a higher rate than did those folks who had a full miss, although the magnitude is somewhat less. Now here's the imaging findings, and I'm not going to go into too much detail here, but what these are basically showing us, and if you look on A here on the left-hand side, is that among control participants, there was greater activation in these reward pathways to a near miss than to a full miss, right? So a near miss compared to a full loss, right? So in people generally who don't have addictions, their brains are going to respond to a near miss almost in a way closer to a win than to a loss. When we look on the right-hand side of these two images, we see the same thing for people with gambling problems, that their response to a near miss is significantly greater than to a loss. But if you look at how bright those areas of the brain are lighting up compared to the controls, we can see that people with gambling problems have a stronger reaction to near misses than do people who are control participants, and that's what the brain diagram at the bottom basically shows, is that problem gamblers have greater differences between their near miss and their full miss than do control participants. So they process these rewards in ways that are different from control participants, in ways that have a greater effect on people with gambling problems. They're more likely to see near misses as a win as opposed to a loss. Now, the sulfuride results, they tried to change the dopamine. It actually didn't work, so I'm not going to get into this slide too much. But what they're basically showing here is sulfuride didn't change anything compared to placebo. So in conclusion, the reward pathways of the brain in response to near misses are amplified in people with gambling disorder compared to controls. And there's no modulation of the brain in response to sulfuride. And this finding fits nicely with the idea that near misses hijack the reward system of the brain and generate problematic learning about skill acquisition. All right, so we're seeing again in this case that there are aspects around reward and processing in gamblers that actually is probably more akin to substance use disorders. Now, a final study that I'm going to present, and then I'll open it up for questions. I'll do this really quickly. Focuses on cravings and cues. So when we're talking about cravings, we're talking about urges we experience, and cues are things in our environment that cue us into that, right? So craving in gambling disorder is often considered to be similar to that in substance use disorder. And cocaine use disorder is the one disorder that's most frequently sort of cited as being similar to gambling use disorder in that sense. And when we're talking about cues, we're often talking about things that make us sort of experience the urge to gamble, for example, even when we're not in the middle of a casino. So maybe we see a billboard that's advertising a casino, or we see a commercial on TV, something that's associated with gambling, but isn't gambling itself. There's a great study done by Mark Potenza's group at Yale University, where they focused on craving and cues, gambling urges. And I'm going to basically just give you the really short version of this, because we're running a little bit short on time. They recruited 114 individuals who had either cocaine use disorder, gambling use disorder, or neither, had no addictions, and exposed them to videos depicting either cocaine use, gambling, or sad scenarios. And what they found, if you look at this graph, which is a little bit busy, if you look at intensity of drug craving on the left, which is graph A, in response to gambling videos, problem gamblers had slightly higher scores than the other two groups. In response to cocaine videos, people with cocaine use disorder had substantially higher drug craving scores than the gambling group and the SAD group. And there were no differences among control participants. In response to other videos, rather. If we look at B, which is intensity of gambling urges, we see that, not surprisingly, people with gambling disorder had significantly greater urges and cravings in relation to gambling videos than to other types of videos. Didn't quite see the same relationship with well, we saw increases in gambling urges among the cocaine-dependent individuals, but it was not anywhere near that of the gambling disorder. And again, we didn't see anything much with the control participants. So this is just in terms of their subjective experiences. When we actually look at their brain responses, they basically found differences between groups and on videos in two parts of the brain. And I'm going to focus on the second part of the brain, because the gambling piece didn't really pan out for the area in the anterior cingulate cortex, which is a frontal area related to gambling and executive function. But the second area, which is the dorsal medial prefrontal cortex and the anterior cingulate cortex, these are areas of the brain that are, as I mentioned when I talked about executive function, are related to reward processing and executive function. And what they found here is that among people with gambling disorder, there was much greater activation in these areas in response to gambling videos than to other types of videos. In cocaine use disorder, there was significantly more interaction in response to cocaine use videos. And there was actually greater activation in the control participants in relation to SAD videos and not the drug or gambling videos. So what this is showing us is that there's similar responses between people with cocaine use disorder and gambling disorder when they experience cues from the environment related to their addiction. So I'll sort of skip this and just very briefly, what does this mean for treatment? The other thing that we often don't talk about is that behavioral treatments and medication treatments have generally come from the substance use disorders. So our cognitive behavioral approaches, our motivational interviewing approaches, and Gamblers Anonymous are all based on substance use approaches. That said, I'm not going to get into the efficacy of these approaches, except to say that for CBT and motivational interviewing, there's a lot of evidence to suggest that it's effective for working with people with gambling problems. And in terms of medication treatments, I'll just highlight that there are a few areas of medication treatment development. Opioid antagonists seem to work with people with gambling problems. There's some initial evidence that glutamate agonists, like N-acetylcysteine, may also be helpful. But it's important to note that there are no FDA-approved medications for gambling disorder, and that's something that we're going to have to sort of deal with in the future. So I'm going to stop there and just see if people have any questions.
We had one from Elaine, and it was regarding studies, which might be a big, it's awful big question for this time that we have. Are there any studies on the impact of trauma on executive functioning?
You know, trauma and executive function not coming to my mind, but we've actually published some research on post-traumatic stress disorder and impulsivity, and we have actually found that impulsivity is significantly higher among people with gambling disorder who also have co-occurring post-traumatic stress disorder. So yeah, the co-occurring sort of aspect of that does seem to be related to at least increased impulsivity.
Yeah, and some of the work that we did here with Josh Grubbs looked at cognitions, which is a little bit different, but you know, and PTSD and gambling, and they had significantly higher irrational cognitions across the board, which is sort of an interesting finding as well. So there is something different going on with folks with PTSD and gambling, and that's why I think they're a little bit more difficult to treat. So be patient.
That's a good future study, I think, though,
yeah.
to specifically look at executive function.
Any other quick questions? I can't see any, and I know we're kind of at the end of time. Oh, there's one more. A correlation between gambling disorder and autism spectrum conditions.
I haven't seen any research in that area. I think that would be interesting in terms of like the stimulation component. You know, if somebody uses gambling in some respects as a way to cope with autism, right? Which we know that people use gambling as a way to cope with things like anxiety and depression and other co-occurring psychological symptoms, psychiatric disorders and so forth.
And then the last question is the predisposition to substance use disorder or gambling disorder. Could pramipexole influence it? That's a good question to ask.
Yeah, I don't know about substance use disorder. Pramipexole can, because it's a D3 dopamine agonist, can result in increased gambling and compulsive gambling. Oftentimes the treatment for that is to reduce or discontinue the medication, and that seems to work in a lot of cases. Yeah.
Well, thank you so much.
Yeah,
I appreciate everybody being here. I hope you have a good lunch, and I appreciate you, Dr. Ledgerwood, coming and spending some time with us.
Thank you so much. I really appreciate the invitation.
Thank you. Take care, all.
Thanks. Bye now.
Thank you. And also, I just want to point out for CEUs, I will be emailing the registration, or I'm sorry, emailing the quiz or the evaluation out to everybody who is here for the full hour. So thank you, everyone. Have a great day.
Thanks, everybody.
It would bring it to 50,000, which is probably